بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم تسليما كثيرا. أعزائي أبنائي الطلبة، يتجدد بنا اللقاء في محاضرة جديدة من محاضرات Ophthalmology Made Easy. كنا قد بدأنا الحديث عن اليوفيتس وأتممنا الحديث عن الفيرال يوفيتس في المحاضرة السابقة بمختلف أنواعها، وفي هذه المحاضرة سيستمر الحديث عن الأنواع الأخرى من الانفكشوس يوفيتس، وارتأيت أن أسرد لكل موضوع محاضرة خاصة به حيث أن الموضوع طويل. فمحاضرة اليوم فقط ستكون عن التوبركلس يوفيتس، ومن بعدها سنأخذ محاضرة عن السيفليتيك يوفيتس، ومن ثم إلى التوكسوبلازموسيس يوفيتس. موضوع اليوم، محاضرة اليوم مهمة جدا، ليست فقط لك طالب في الدراسات العليا أو في الامتحان، ولكن للوقوف على أهمية وخطورة هذا المرض الذي هو متواجد بيننا ومتفشي حاليا في ليبيا. وستكتشف من خلال ما سأسرده إليكم أهمية وخطورة هذا المرض للاطلاع على كيفية التشخيص وعلاج هذا المرض الخطير، ومعرفة الأشكال المختلفة التي ممكن أن يتشكل بها the clinical features that can present for you when you are in the outpatients. وبالتالي نتوكل على بركة الله ونبدأ بالحديث عن التوبركلس يوفيتس. بادئا the table of content of this lecture, we will cover the epidemiology of tuberculosis as well as the ocular tuberculosis and the pathogenesis underlying this disease. We will speak about the clinical spectrum from anterior uveitis to intermediate and posterior uveitis, and then we will speak about the diagnostic dilemma and the problems of the skin test and the serology and some of important investigation and the multimodal imaging techniques. And we will speak about the management and the treatment and the use of anti-tubercular drugs and the side effect of this medication and the emergence of multidrug resistance. And finally, we'll speak about the prognosis and the future prospect of this disease. Now, before we start our lecture, I want you to check these questions and check or evaluate your competence on answering these questions. If you are able to answer these questions, so your knowledge regarding this topic is good and you are in a good position. However, if you cannot answer these questions, so you should listen carefully in this lecture, because at the end of this lecture, definitely you will be able to answer all these questions. Now, can ocular tuberculosis appears without pulmonary tuberculosis? And which anti-tubercular drug is mostly associated with toxic optic neuropathy? And which of the following is considered most suggestive of tuberculous uveitis? The non-granulomatous anterior uveitis, serpiginous-like choroiditis, Fox heterochromic uveitis, or acute retinal necrosis? Another question is, which investigation has the highest specificity for active ocular tuberculosis? Which one is more specific for TB in this investigation? And which feature most favor of the ethambutol toxic optic neuropathy over tuberculous optic neuropathy? And also, in the context of recent update for evaluating suspected tuberculous uveitis, what's the primary clinical advantage of interferon gamma release assay over the traditional tuberculin skin test? You should know about this. Also, what's the primary route for ocular infection? Is it direct spread from tuberculous keratitis, for example, or tuberculous scleritis, or it is a hematogenous spread from miliary tuberculosis, or reactivation of latent infection, or if discovered, it suggests immune suppression and comorbidity like HIV. Of course, when we speak about the ocular tuberculosis, we as ophthalmologists, we should not neglect what's written about tuberculosis as a whole from the WHO reports. I revised many reports. This is some of them. And these are the links that you can scan and go and read yourself. What's important for me here, I want to see what's the situation of our country, Libya, regarding this pandemic problem, regarding the ocular manifestation of tuberculosis. Now, as reported by the WHO, TB remains the world-leading infectious disease killer. That's around 1.25 million are dying per year. And ocular involvement represent 1 to 10% among all cases of tuberculosis. And actually, this figure is not accurate or fixed figure because it depends on the endemicity and the location, depends on the infrastructure of the medical personnel and medical system, because it depends on the early detection of the disease as well as the ability of the medical people to identify tuberculous uveitis. There are many countries, they have very high prevalence of tuberculosis, but there is low prevalence of ocular involvement, and this is not because of the low incidence, it is because of they are missing the cases. A lot of cases of ocular tuberculosis are missed as idiopathic, especially the immunogenic variety. There, as you know, and we will discuss later, that among the pathogenesis of the tuberculosis uveitis is the immunogenic hypersensitivity or delayed hypersensitivity reaction. So these people will respond to topical steroids. So there are a lot of cases they missed as idiopathic uveitis, but they are actually tuberculous uveitis. The reason why, because accurate diagnosis for ocular tuberculosis is very difficult, and we used to say this is a presumptive diagnosis. Presumptive means that based on the clinical finding and based on the radiology and serology, it is highly suspicious or probable that this is a case of ocular tuberculous uveitis. We don't accurately diagnose it because we cannot identify the organism inside the ocular tissues, because it is a paucibacillary disease. Paucibacillary means very low bacterial load inside the ocular tissue. So it is a presumptive diagnosis, unlike in pulmonary tuberculosis, in which the diagnosis is primarily based on the identification of the bacilli in the sputum of the patient. That's why this figure is always variable from country to country and based on many factors. Now, if you look to this report made by the WHO in the 2024 showing the TB burden worldwide, now what's bothering me is about Libya. It shows the prevalence of the disease between 50 to 99 cases per 100,000 population. So per 100,000 we have 50 to 99 cases. Now they compare it with 2015. The number was less. That's why we have an increase by about 5% from the year 2015 till now. So there is increment by 5%. That's why when you look to the map, you find Libya with the special color because they have increased, and adjacent countries they have decreased the prevalence of tuberculosis. So this should flag or raise the flag or the alarm for the responsible people to take action against this problem. And also for us as ophthalmologists, we should keep our differential diagnosis of tuberculous uveitis in our list. And when you find a patient with unilateral granulomatous uveitis and with other findings suggestive of tuberculosis, along with the screening for tuberculosis like the tuberculin test or the IGRA test, we have to notify the authorities, and we have to take actions against the treatment of this disease. Now, so the prevalence of the ocular tuberculosis is not exactly known, but it is ranged between 0.2 to 10%, and in some endemic area can reach up to 20%. As I said, based on the skills of the medical people who can identify the signs of the ocular tuberculosis and notify the authority regarding this disease. And keep in your mind that 90% of the patient with ocular tuberculosis not necessarily have concomitant pulmonary tuberculosis. And this is the answer for the first poll questions that I have placed in the beginning of the lecture. You should not rely on detection of pulmonary tuberculosis to diagnose ocular tuberculosis. Okay, so 90% of the people who present with ocular TB, they don't have concomitant pulmonary tuberculosis. They might have evidence of old or previous exposure based on the X-ray or CT scan of the lung, or based on the serology of the tuberculin or skin test or the IGRA test. However, active tuberculosis is not necessarily a prerequisite for diagnosis of tuberculous uveitis. So the gold standard to have a definitive diagnosis, we have to isolate the organism. However, this is practically very difficult, and even with the use of PCR, it is difficult to identify the mycobacterium in the aqueous fluids. That's because it is a possibacillary disease. That's why the diagnosis is presumptive, as I mentioned earlier. Keep in your mind that in the presentation of ocular tuberculosis in 60 to 80% is due to the immunogenic hypersensitivity reaction to the antigens of the Mycobacterium bacilli, and only 20 to 40% are due to active replication of the organism itself. That's why we have to use a combination of steroids as well as anti-tubercular treatment in dealing with these patients. And also, as I said, the ocular involvement can reach up to 20% in endemic places. Starting with the ocular manifestation of ocular tuberculosis, external eye manifestations. One of them is the flectinular conjunctivitis. This is a small yellowish nodule seen around the limbus, represent hypersensitivity to the Mycobacterium bacilli antigens, and can be seen in children commonly and also in adults. Also, patient can present with granulomatous conjunctivitis or scleritis. The cornea can be involved by interstitial keratitis, and this is a ghost blood vessels indicate old inflammations. Anterior segment, the classical type is the granulomatous uveitis, and hypopyon is a rare manifestation of tuberculosis. If you see a patient with tuberculosis and hypopyon, think an immune suppression, coexistence of HIV infections, or as a complication of the drugs. As you can see later, that ethambutol is one of the drugs that can cause hypopyon. Otherwise, if the patient is not known to be positive for tuberculosis, think on HLA-B27 if you find this hypopyon. So the uveitis is granulomatous with mutton fat KBs, granulomas in the form of copy nodule, Posaka nodule, also granuloma in the anterior chamber here, and also by gonioscopy you can see Berlin's granulomas, as we spoken before, but it is commonly seen in sarcoidosis. The most specific feature in the anterior segment that points to tuberculosis is the presence of what's known as the broad-based posterior synechia, that I will show it in the next slide. Broad-based synechia shows high specificity, nearly 93% indicate that this is tuberculous uveitis or tuberculous eye disease. Now, this table of one major study done at India regarding the specificity of broad-based posterior synechia. Broad-based posterior synechia shows very high specificity in the anterior segment inflammations that points to the tuberculosis, although it has low sensitivity. It means that if you find this sign, it is highly suggestive of tuberculosis. However, absence of this sign does not rule out tuberculosis. This is the meaning of low sensitivity but high specificity. Keep it in your mind, along with the other features of the patient present with posterior uveitis. As I said, serpiginous choroiditis and vasculitis also carries a very high specificity for ocular tuberculosis. Now, this is the broad-based synechia. This picture, if you find this picture in the slit lamp, always think in tuberculosis and you have to investigate your patients. Okay, this is the broad-based synechia. The second important manifestation of ocular tuberculosis is the intermediate uveitis. And actually, intermediate uveitis and tuberculosis is a broad spectrum ranging from vitritis, severe vitritis, to snowball opacities within the vitreous and snow banking. And the characteristic feature of snow banking is predominantly in the inferior part of the peripheral part of the retina. And also there will be peripheral retinal vasculitis, and the reason why this area is much more common, because this area is sandwiched between two highly vascular zones, between the pars plicata, which is highly vascular, and the peripheral part of the retina and choroid, which is also highly vascular. That's why you'll find the snow banking are present at the far periphery of the retina, at the region of the pars plana, and it is commonly in 75% of the cases in the inferior part, rarely seen in 360% degree, and very rare superiorly. So it's very important. If you find more than 3 clock hours with severe vitritis, always think in tuberculosis, especially if the patient is more than 40 years and usually bilateral to differentiate it from other causes of intermediate uveitis. So this is the vitreous cells, severe vitritis. There will be there, unlike other diseases like in multiple sclerosis. This is the peripheral corneoretinal scars, snowball opacities within the vitreous, which is represented exudates within the vitreous, and snow banking opacity in the inferior part with severe vitreous haze. So all this picture is suggestive of tuberculosis, and you should screen your patient for skin test or for serology for IGRA test. Now, we have one bullet question. What's the rationale behind using anti-tubercular medication in treating tuberculous intermediate uveitis when the evidence suggests immune-mediated hypersensitivity mechanism? Is it contraindicated to use anti-tubercular drugs in managing intermediate uveitis, as usually there is a PCR negative or no intraocular inflammation detected by PCR? Or is it mandatory always which represent direct infection from the Mycobacterium bacilli? Even with PCR negative, this may be false negative. Or it is important to use the combination of steroids and anti-tubercular drugs to eliminate the antigenic stimulus from latent tubercle foci, so that we reduce the recurrence by 50%, that allow steroid for tapering. Or we have to defer anti-tubercular treatment, that's we use the immunosuppressant first, that is immunosuppressant, the steroids or whatever, then we add anti-tubercular treatment later on, 3 to 6 months later. Or the use of INH, that's isoniazid monotherapy, only in latent tuberculosis with immune complications. Now, the aim from this question, that although we know that the mechanism of intermediate uveitis is mainly immune-mediated mechanism, however, when we are treating intermediate uveitis, we use both steroids and anti-tubercular treatments together. What's the rationale behind that? The answer is that it is mandatory for you to combine the use of both, of anti-tubercular and immune suppression, because even if you have a negative PCR, this might be false negative, because this is postbacillary tuberculosis, and detection of DNA particles within the fluids from the eye is very difficult. And another thing, that even it is immune-related mechanism, by the use of anti-tubercular drugs, you destroy any latent Mycobacterium bacilli present, so that you will prevent the release of any antigens and control the inflammations. So even it is immune-mediated, but you have to use both the anti-tubercular as well as steroids. Now we come to the most important presentation of ocular tuberculosis, is the posterior uveitis, and we will pay more attention in this lecture about this presentation. We will discuss all of these points: the choroidal granuloma, serpiginous-like choroiditis, focal and multifocal choroiditis, subretinal abscess, vasculitis and optic neuropathy, and also toxic optic neuropathy. And we will mention the difference and the differential diagnosis of serpiginous-like choroiditis, that's the classical type of serpiginous choroiditis, and we will speak about the visual prognosis and the spectrum of the use of anti-tubercular drugs. One of the important things for you as a postgraduate student to be able to answer this question regarding the difference between tuberculoma and choroidal tubercles. As the name implies, tuberculoma refers to the single solitary mass, yellowish in color usually, occupying the posterior pole of the patient of a presumed ocular tuberculosis. And why the posterior pole? Because this area is highly oxygenated, as you know, near to the macula, and based on the principle of tropism, that the Mycobacterium bacilli, they have predilection for the highly oxygenated structures like the lung and the posterior pole near to the macula. So usually it is a single solitary mass, sometimes associated with retinal detachment, and it comes in the differential diagnosis of single solitary mass in the posterior segment, including TB, sarcoidosis, posterior nodular scleritis, and sometimes melanoma, and so on. In fluorescein angiography, as you can see, in the early stages, there will be masking of the background choroidal fluorescence, and in later stages there will be late staining and late leakage, and this masking because of the highly granulomatous inflammation inside this lesion, which is containing the bacilli of the mycobacterium. Both of them represent the same spectrum of the disease, that both of them contains or due to miliary tuberculosis with associated severe granulomatous inflammation to try to restrict the invasion of the mycobacterium tuberculosis in the posterior segment. Now, when you see the ICG for this patient, the same thing, you will find a fixed dark spot in the circulation of the choroid. This is very important, which is not changing over different stages of the ICG. And on ultrasound, you will find a mass with high to medium internal reflectivity by A scan. This is important to differentiate it from melanoma or other tumors. So this is the features of tuberculoma. Sometimes it is associated with retinal detachment, as you can see here. Severe sensorineural detachment associated with vitritis, usually severe vitritis is associated, and by OCT you can see the subretinal fluid collection, disruption of the outer retinal structures, and severe large mass occupying the choroid and pushing the retinal pigment epithelium, causing undulation of the retina. This is tuberculoma, and you see that lots of the fine details of the outer retina. This is called the contact sign. That's upon contact with the retinal pigment epithelium, there will be disruption of the details and no more details can be seen. Okay, and this is another tuberculoma, just shows new vessels, a new vascularization over the surface of the tuberculoma. And this is because usually tuberculoma is associated with occlusive vasculitis, so there will be new vessels. This is important to differentiate it. We will speak later about sarcoidosis, in which there will be no occlusive vasculitis in sarcoidosis. Similarly, this is tuberculoma, and this is the corresponding masking effect that's seen on ICG, characteristic for this tuberculoma. So tuberculoma in summary is a single mass, solitary mass, large, associated with retinal detachment, and maybe associated with a new vessel formation. Now, on contrary, the choroidal tubercles is multiple, is not single mass. You will find more than one lesion, also yellowish in color, occupying the posterior pole and elsewhere, and usually small in number, reflect the miliary tuberculosis, and also the same pathology, that there will be granulomatous inflammation that might lead to caseation later on. So this is the main differential point between choroidal tubercles and tuberculoma. Now, an important point that for you as a postgraduate, you need to know how to differentiate between tuberculous granuloma and granuloma caused by other diseases like sarcoidosis. The most important differential diagnosis for tuberculosis is sarcoidosis. From the etiology, you know that the tuberculous granuloma is due to a granuloma, caseating granuloma formed due to invasion of Mycobacterium bacilli, and the immune system will form a granuloma around it, trying to destroy them, and at the end there will be caseation. However, in sarcoid granuloma, it is an autoimmune disease related to the immune system, but there is no infective organism so far determined. Clinically, both of them, they appear as white, yellowish, multiple spots, single or multiple spots, and in tuberculosis, usually elevated spots with overlying new vessels over it. This is due to occlusive vasculitis. However, in sarcoidosis, it is with defined edges, and usually there is no elevation of the overlying retina, and there will be no new vessels over it because there will be associated non-occlusive periphlebitis. So you'll find sheathing of the blood vessels of the veins and hemorrhages, but you will not find occlusion. So then this is evident by fluorescein angiography. In tuberculosis, you will find large areas of capillaries non-perfusion due to occlusive vasculitis. However, in the sarcoid granulomas, there will be no loss of capillary non-perfusion because of the non-occlusive periphlebitis. This is important. However, clinically, it might be very difficult to differentiate both of them, and you need to do further investigation to try to define or find out whether this case is sarcoidosis or tuberculosis. Another important gold standard for the differentiation is the use of ICG. Now, ICG has particular features. Both of them, they will show hypocyanescent areas in the ICG angiography, And the characteristic feature in tuberculosis that you will find the number of the hypofluorescent spots is less than the numbers which are seen clinically. So clinically you will see, for example, 5 to 10 spots. By ECG you will find the number is less. However, in sarcoidosis, the reverse. You will find the hypocyanescent areas is much more than what you have seen clinically, because the sarcoid granuloma is sometimes unevident, as you see here, very small, faint, you cannot recognize them. This is a characteristic for the difference between both of them. Now, another thing comes is sometimes how to differentiate between choroidal tubercles, if the patient has multiple choroidal tubercles, and multifocal choroiditis due to tuberculosis. Now, the distinction between of them is important because the multifocal choroiditis is usually autoimmune disease or due to immune-related mechanism, due to the delayed hypersensitivity reaction to the antigens of the bacilli. So the role of steroids is important here. Although we have to use anti-tubercular drugs, but the role of steroids is important. However, in choroidal tubercles, due to active invasion of the mycobacterium bacilli to the retina, so the role of anti-tubercular drugs are very important here. So the distinction sometimes is important. However, both of them belong to the same spectrum of the disease, that is ocular tuberculosis, and that's why when we are not on solid ground to exactly determine the diagnosis, we say presumed ocular tuberculosis. We will not say ocular tuberculosis because we are not confident enough, so we'll say presumed ocular tuberculosis. You can see this is the fundus picture of the patient with multiple yellowish white spots scattered all over the fundus. Clinically, we cannot say that this is tuberculosis, but if you are in an endemic area, the first differential diagnosis comes to you will be tuberculosis. When you do fluorescein angiography in early stages, you can see that there is very small, faint, hypofluorescent areas masking the underlying choroidal circulations, and this spots becomes evident and leaky at late stages. So this is suggestive of multifocal choroiditis, but you cannot say that this is due to tuberculosis unless you calculate other factors, as I said, the endemic area and so on. Now this is the ICG. You can see the hypocyanescent areas, multiple hypocyanescent areas in the choroidal circulations, suggestive of multifocal choroiditis. So this is a case of multifocal choroiditis, and if you do the OCT, you will see the same things in the area of the choroid, especially with high resolution swept source OCT and the extended depth OCT. You will find hyporeflective areas in the areas of the choroid, sometimes associated with dracenoid appearance with elevation of the retinal pigment epithelium over, and this is also some element of elevation of the retinal pigment epithelium. So this is multifocal choroiditis. Now we come to the one of the important manifestations of the presumed ocular tuberculosis is known as the tuberculous serpiginous-like choroiditis. And the reason why it is named serpiginous-like choroiditis because it is different than the classical one. There is one classical variety of serpiginous choroiditis that's an autoimmune problem. We will compare it later with this phenotype. However, this is due to tuberculosis, so it is called tuberculosis serpiginous-like choroiditis. And serpiginous refers to as amoeboid branching choroiditis that's usually originating from the posterior pool and is characterized by multifocality. This is very important. You have more than focus, multifocality, and it has amoeboid indistinct borders. So that's why it's called serpiginous. Okay, usually associated with mild vitritis. And of course, the most important is the fluorescein angiography and ICG. Fluorescein shows early hypofluorescence that later on will shows hyperfluorescence with this fuzzy margins, irregular margins. And also what's known as fundus autofluorescence. This is also important. Diagnostic tool or imaging modality also shows hyperfluorescence because of the impaired metabolism of the retinal pigment epithelium, so there will be associated hyperfluorescence due to the choroiditis itself. This is without fluorescein. And OCT will show the characteristic disturbance of the outer retinal layers. You can see the outer retinal layer is totally disturbed, and also the hyperreflectivity of the choroid. You see the choroid is very clear with patches of choroiditis present, and also projections of the retinal pigment epithelium like a drusonoid pattern projecting inside the outer retinal layers. So this is characteristic of the tuberculous serpiginous-like choroiditis, and this is due to active invasion by Mycobacterium tuberculosis, along with severe inflammatory reaction. That's why in the tuberculous serpiginous-like choroiditis, we need to provide both the anti-tubercular treatment as well as the steroids or immunosuppressive treatment. This is another picture, classically multifocality, and one of the another differentiating point is the presence of vitritis. You will find with vitritis, that's why you see the picture is hazy, but the multifocality is very important to differentiate it from the classical variety of serpiginous choroiditis. And this is very clear and very evident by the ICG. By ECG, you find that the lesion inside the choroid is much more than what you see clinically. So you will find multiple hypofluorescent areas or hypocyanescent areas present in the choroid. And another feature that you will find associated systemic finding that points to the underlying disease. For example, this is associated with episcleritis or scleritis. So this is most likely tuberculosis. To compare it or differentiate it from the classical variety, which is not associated with systemic diseases. So if you find patient have scleritis along with vitritis, and this picture, so this is more of tuberculous serpiginous-like choroiditis. This is very important differentiating point from the classical one. Now this is the classical variety of serpiginous choroiditis. The classical variety differs than the tuberculous-like, that it originates from the peripapillary area. That one originated from the posterior pole near at the macula. And similarly, it is not multifocal. It is usually spread centrifugally and involves the macula later and start from the peripapillary area with pigmentation usually at the advancing edge. You will find the pigmentation at the advancing edge. Unlike the tuberculous-like, you will find the pigmentation within the center. And this is usually a bilateral problem. Bilateral problem because it is an autoimmune problem. Unlike the tuberculous one, which is usually unilateral, you can see the fundus is very clear. There is no associated vitritis, no associated systemic diseases. And this is the ICG, has the characteristic hypofluorescence or hypocyanescence, and you see that the lesion by ICG is much more than what you see clinically. This is very important. And we don't have the fundus autofluorescence picture, but this is all the modalities that we have to do for such patients. Apart from the laboratory investigation, like the interferon gamma release assay and the tuberculin test, we have to do the fluorescein, we have to do the OCT, ICG, and fundus autofluorescence. All these are very important. So this is another picture, the classical variety of the serpiginous choroiditis. You can see clearly it is peripapillary and spread in amoeboid fashion. And as I said, that the characteristic feature in the ICG, that you will find areas of hypocyanescence that's present in the early stages of the ICG angiography, as well as persist even in late stages. You see, there is no difference. There is no leakage here. This is suggestive of choroiditis, and also is associated with choroidal hypoperfusion. Here is a summary for the difference between the tuberculous serpiginous-like choroiditis and the classical variety. This is very important postgraduate questions, and you should be able to answer. First of all, as far as the etiology, the tuberculous variety is due to Mycobacterium infections, and the classical variety is autoimmune idiopathic cause. The pattern, as I said, in the tuberculous variety usually multifocal and non-contiguous. However, the classical one is peripapillary and spread in geographical amoeboid fashion. Vitritis is present in the tuberculous variety, however, it is absent in the classical one. And laterality, tuberculosis usually affecting one eye, unilateral, unless very rarely, if it is bilateral, it will be asymmetrical, especially in immunocompromised patients. However, the classical variety usually bilateral and recurrent. Okay, And the characteristic feature in the OCT, you will see the granuloma, edema, hyperreflectivity, and the characteristic appearance in the OCT. However, in the classical variety, the wedge-shaped atrophy of the outer retinal layers, you will see it because of the long-standing property and the recurrence of the problem. Now, the distinction is important. Why? Because the tubercular variety, we have to use both anti-tubercular treatment as well as steroids. However, in the classical variety, you need only immune suppression and no need for the use of anti-tubercular drugs, and no need to expose the patient to the toxicity of tuberculosis if you miss the diagnosis. So it is not just empirical, you provide both treatment, you should be precise on your diagnosis. So the main points that you should mention to your examiner: presence of vitritis is in favor of tuberculous variety, along with multifocality, and peripapillary creeping. Peripapillary 1 is characteristic of the classical one, usually without vitritis. So this is the classical variety you can see surrounding the optic nerve, peripapillary, and this is the multifocality due to the tuberculous variety. Here also I will provide some of the differentiating point also between the classical type and the tuberculous type of serpiginous choroiditis. In the tuberculous type, there will be much more disturbance for the normal architecture of the retina, especially the outer retina, and also the vitreous interface will be disturbed. And also, as you can see, the small spots of intraretinal edema, and also disturbance for the ellipsoid zone and the deposition of ellipsoid-like material under retinal pigment epithelium, and the hyperreflectivity area of the choroid. This hyperreflectivity is seen in both actually, but this is suggestive of ischemia for the choriocubellaris in the choroid. And this can be also seen, this is by structural OCT. However, by OCT angiography, you will see hyporeflective areas, or what's known as low void. Low void indicate ischemia. Similarly, the hyperreflectivity here in the outer retina, this is the Henle layer, is indicative of severe ischemia, may be associated with arterial occlusion, branch artery occlusion. So this is the main features in the tuberculous type. The classical type, you will see more preservation of the outer retinal layers. Similarly, the changes in the choroid area is there and multifocal, and usually in the superficial part of the choroid, not deeper part. Unlike in the tuberculous type, you'll find superficial and deep layers is involved. And this is the fundus autofluorescence picture as well. Apart from the fundus picture that I have explained before, that is the classical type will be peripapillary, it has centrifugal distribution, and they are unifocal. Usually both eyes are involved. In the tuberculous type, usually unilateral, or you find multifocal spots, but usually one eye is involved, and borders with ill-defined, and this is the active borders. And when you do the fundus autofluorescence, you see this autofluorescence suggestive of activity. This brightness here suggests that an active choroiditis. There is active choroiditis. Once the choroiditis is hit, you will not see this autofluorescence. So you should memorize at least 2 to 3 points, important point, how to differentiate both of them. Because I said before, the differentiation is very important. This is absolutely autoimmune process and need steroids. And this is due to infection with mycobacterium and need combination of both steroids and anti-tubercular. Don't forget the face, the vitreous phase interface will be disturbed in the tuberculous type, along with significant disruption of the architecture and the contour of the retina in tuberculous serpiginous-like choroiditis. Now we come to one of the important presentations or manifestations of tuberculosis or ocular tuberculosis is the retinal vasculitis, which takes predominantly the shape of occlusive periphlebitis. So it starts involving the veins with perivascular sheathing. Then there will be a progression to severe ischemia and areas of capillary non-perfusion that can be seen by fluorescein angiography. You find the new vessels formations and areas of capillary non-perfusion. Better to use the wide field picture to see the far periphery, or by the fundus camera you can take multiple pictures for the far periphery to see these new vessels. As you can see here, this is the leakage, and it will be complicated by cystoid macular edema. And in advanced cases, there will be also rubeosis iridis and new vascularization, even involving the vitreous, and present with vitreous hemorrhage inside sometimes, and also tractional detachment. And rubeosis iridis can present with secondary glaucoma. So perhaps this is the most common cause for surgical interventions, or sometimes doing laser treatment to the ablate the far periphery. So one of the clues that points to the tuberculous origin of this periphlebitis, that you find a perivascular granulomas around the sheathed blood vessels. As you can see here, this is areas of hotspots of leakage due to underlying granulomas around the sheathed blood vessels. So when you see this picture in fluorescein angiography or in fundus photography, always keep tuberculosis in your mind, that you should make sure that this patient has tuberculosis or not, so that you can combine anti-tubercular treatment along with any interventions you want to do for these patients. So this is the characteristic feature that gives a clue to the tuberculous origin, is the presence of perivascular granulomas. Now we come to the other phenotypic presentation of tuberculosis. It's present as Eales-like disease. Now you know that there is one idiopathic variety which is known as Eales disease, and now TB is thought that it could be a sub-variety of the idiopathic Eales disease, or it has a special phenotypic presentation. So for you as a student, when you are asked about the retinal involvement or vascular involvement in tuberculosis, you have to mention the vasculitis related to tuberculosis in the form of occlusive periphlebitis, or the Eales-like phenotypic presentation. Now, the first question, how we differentiate between this Eales type phenotypic presentation from the classical periphlebitis or occlusive periphlebitis in tuberculosis. Now, in this presentation, the presentation is much more broader in the whole quadrants. The previous one was just sectorial in one or two quadrants. And here it is more peripheral. The other one is more mid-peripheral, the involvement in the mid-periphery, and is associated with granuloma. As I said, that the perivascular granulomatous inflammation. However, here you will find the involvement very far periphery, and there is no much granulomatous inflammations, also minimal vitritis or anterior segment inflammations. However, in the perivasculitis or occlusive periphlebitis, you will find vitritis and also sometimes anterior segment involvement. Now, this is more worse because associated with more ischemia, more new vessel formation, and more complication in the form of hemorrhages and rubeosis iridis and so on. You can see the huge involvement with the new vessel formation and perivascular sheathing. Similarly, the extensive leakage here and wide areas of capillaries non-perfusion. Similarly, you can see here the wide areas of capillaries non-perfusion. Now, the other question, how we differentiate between if the patient presents like this and there is no any clue for underlying tuberculosis, because mostly these patients, the etiology is hypersensitivity reaction to tuberculous bacilli, and sometimes you don't find any evidence for previous exposure to tuberculosis. So the only evidence that you might find a positive Manto test, that's tuberculin test, or positive IGRA test, that is immune gamma interferon gamma release assay, or sometimes you find old evidence on the chest X-ray on the apex of the lung. You find some evidence of old inflammation. Otherwise, you might not find any evidence of active tuberculosis in these patients. This is important to differentiate it from the idiopathic variety of Eales disease. The idiopathic variety will not find any evidence of previous exposure to tuberculosis. So in this patient, before you start in any treatment, you have to at least do the chest X-ray, CT scan of the chest, you do the tuberculin test, the IGRA test. Now, if you find positive for any evidence of tuberculosis, you have to combine your treatment with anti-tubercular treatment. This is the difference. Because if you just give steroids only without anti-tubercular treatment, you might worsen the situation. So my message for you, you should know how to differentiate between Eales-like phenotypic presentation of tuberculous vasculitis and from the idiopathic variety of Ehlers disease. This is number one. Number two, how you differentiate between Ehlers phenotypic presentation of tuberculosis and from the classical occlusive vasculitis also or vasculopathy that's seen due to tuberculosis, as well as I have explained earlier. Now we come to one of the important also phenotypic presentation of tuberculosis involvement of the eye, namely the posterior segment, is the involvement of the optic nerve in a spectrum named as optic neuropathy, ranges from optic neuritis, perineuritis, granuloma, or optic disc tuberculoma. And keep in your mind that this granuloma can be present on the fundus, that you find it in the optic disc, or you can see it or present along the course of the optic nerve and even into the brain and the chiasma and so on. So MRI is important to document such lesions. That's why tuberculosis of the eye is one of the great mimicker or masquerade syndromes that can mimic many other diseases. For example, this scenario can mimic the demyelinating disorders. So you should differentiate it from demyelinating disorders by doing the needed investigation, and you find the typical plaques seen in multiple sclerosis and the periventricular white matter presence of the plaques around the periventricles. However, in tuberculous variety, you should support your diagnosis apart from the pattern of presentation by history of previous exposure, by positive tuberculin test or the IGRA test. Also, the chest X-ray is important in these cases. And along with the fundus picture, if you find evidence of previous and old granulomatous inflammations, this may give a clue to the underlying etiology, which is tuberculosis. The distinction here is very important, because if we are planning to treat this presentation with steroid only, this will complicate the scenario, and you have to combine it with anti-tubercular treatment. And keep in your mind that anti-tubercular treatment itself might induce some toxicity to the optic nerve, named as the optic neuropathy due to ethambutol and isoniazid. So you have to precisely determine what's the underlying pathology for your presentation. Now, this is an example of tuberculoma with juxtapapillary area involving the retina as well as the adjacent optic nerve. And on ICG, you can see the area of hypocynosance, which is present in the choroidal circulations, which is present during the whole stages of the ICG. And similarly in the fluorescein angiography, which shows late leak from the same area and leak from the optic disc. So this is juxtapapillary tuberculoma due to tuberculosis. And also one of the presentation as optic neuritis with neuroretinitis, perineuritis. You can see the severe inflammations and hemorrhages and blurring of the disc margins, and this patient need OCT. You will see the retinal edema as well as the presence of intraretinal or subretinal fluids as well. So always keep tuberculosis in your differential diagnosis for such presentations, and keep it in your mind that tuberculosis is one of the great mimicker that might mislead you and give a wrong diagnosis if you don't keep it in your mind, especially in endemic areas. Now, this is another bullet questions. Provided this patient has positive test for quantiferon, what's the most characteristic imaging sign for active tuberculous serpiginous-like choroiditis? Now, the diagnosis is given that this is a case of serpiginous-like choroiditis. He's asking about the fluorescein and ICG features of this condition. Is there immediate or uniform hyperfluorescence of the lesions seen by fluorescein angiography in early phases? Or you can see hypofluorescent lesions that persist throughout the stages of ICG with fuzzy borders, or complete absence of subretinal fluids or retinal pigment epithelial changes, or centropedal healing with lesions always starting at the optic disc and spread peripherally. Now, as we said before, this is the tuberculous serpiginous-like choroiditis, which often presents as multifocal non-contiguous lesions, as you can see here. And by ICG, as you can see, there will be areas of hypofluorescence that persists throughout all the stages of ICG. So the correct answer will be B. And this is the hypofluorescence suggestive of ischemia due to granuloma formation, and there is non-vascularization of these areas or severe ischemia in these areas. And on fluorescein angiography, this is called the Hubbard spots or creeping hyperfluorescence. Now, this hyperfluorescence will not appear immediately as it is written here in the fluorescein angiography stages, but it will appear initially as hypofluorescent spot, then later on they will show hyperfluorescence due to the leaking from these lesions. So the correct answer is B, which is hypofluorescent lesions that is persist throughout all stages of ICG. Now, this is the picture after treating these patients. As you can see, the pigmentation and the healing process. So this is before the starting of the anti-tubercular treatment, and this is by the end of the use of anti-tubercular as well as steroids. So there will be areas of pigmentation. So this indicates old healed serpiginous choroiditis. Now, to differentiate, or one of the most important differential diagnoses of this problem is, as I said, the classical type of serpiginous choroiditis, in which this one is usually around the optic disc and spread centripedally, as he's giving you a hint here, the centripedal healing. So in the classical variety, it will be centered around the optic disc, and there will be changes in the retinal pigment epithelium and the outer retina, as seen here, which is also seen in the tuberculous-like choroiditis. But this is usually centered and usually bilateral and usually around the optic disc, unlike in the tuberculous variety, which is usually around the posterior bole, not necessarily involving the optic disc. Now we will come to an important section of this lecture, that we will together review the modern anti-tubercular therapy relevant to the ophthalmologist, and also focusing not only on the traditional tubercular treatment, but also on the newer and the novel agents that's used for the treatment, and the paradigm emerging varieties of tuberculosis, like the latent tuberculosis and drug-resistant disease. And we will discuss the different regimes for the resistant types of tuberculosis. Now, this issue is related for you as ophthalmologists, because you will note and discover during our discussion that there are a lot of drugs that's used especially for long duration in drug-resistant tuberculosis, that affects the eyes and also affect the optic nerve and cause complications to the eye, so that you need to follow and manage your patients accordingly, and you should be aware of the different definitions of the drug resistant and so on. So let's dive deeply and discuss together briefly about the anti-tubercular treatment in a quick. Now, as you know, the modern concept as defined by the WHO, that tuberculosis is not just an latent or active and inactive disease. It is a broad spectrum ranging from the initial exposure of the disease. Some people just on exposure of the tuberculosis, they need to have special care and treatment. Then some people, they become latent. Latent means that they have positive serological testing without any clinical manifestations. And it might extend to be a subclinical case, that's patient with ocular tuberculosis without any evidence of pulmonary tuberculosis. And it might progress to be an active tuberculosis or pulmonary tuberculosis or other parts of the body. And it might end up with a drug-resistant tuberculosis. So based on the WHO, the tuberculosis is a broad spectrum starting from the exposure up to the drug resistance. And for us as ophthalmologists, we should know that the pulmonary tuberculosis is not exactly same as ocular tuberculosis. In pulmonary tuberculosis, we are dealing with sputum microscopy and the culture and the isolation of the organism from the sputum, and finding cavitations in the X-ray or in the CT scan. However, in the ocular tuberculosis, we are relying mainly on the phenotypic presentation and recognition based on the multimodal imaging by the use of the serology, IGRA or TST, And also we sometimes in some cases do therapeutic testing for the anti-tubercular treatment and see the response. And also we have a lot of mimickers like syphilis and sarcoidosis. We have to exclude them, so that majority of the time we cannot isolate the organism from the fluids from the eye, so that we say that this is presumed ocular tuberculosis. We cannot say definitely that this is tuberculosis based on the microbiology or laboratory testing, because it is very difficult to isolate the organism from the eye fluids. Also, the ocular tuberculosis is extrapulmonary and paucibacillary. Paucibacillary means that you have very minimum organism, but you have significant inflammation inside the eye because of the special nature of the eye, that is an immune privileged structures. And also the presentation is different. You will find presentation due to direct microbial multiplication inside the eye, and also presentation due to delayed hypersensitivity reactions and immune mediated inflammation. So you have a broad range of presentation in the eye. That's why we have to keep all these information in our mind when we are willing to start anti-tubercular treatment for a presumed ocular tuberculosis. This is important bullet question, that while you are treating a patient with mycobacterial infections and suddenly you notice deterioration and he has hypopyon in the anterior chamber with sudden deterioration, as you can see here. Now, what's the most likely cause for this problem? Is it a sudden burst of the tuberculous bacilli into the anterior chamber, or a side effect of the medication like rifabutin, or reactivation of latent Gons complex in the lung, or a paradoxical immune response, which is the MAC syndrome, which stands for Mycobacterium avium complex, due to infection by Mycobacterium avium and intracellular, which are atypical mycobacteria. So what's the correct answer, do you think, for this patient who has sudden onset of hypopyon in the anterior chamber? Now, the answer for this question, that this patient is usually a complication of the drug, which is the rifabutin. Keep it in your mind. Rifabutin is not rifampicin. The rifabutin is belong to the same class of rifampicin, but it is mainly used in patients with tuberculosis and HIV infections, because they are prone for the opportunistic infection from the atypical mycobacterium, as I said, the Mycobacterium avium and intracellular. So these patients, once they given this rifabutin, especially in high doses and due to the drug-drug interactions, they will show hypopyon, which is rare finding in tuberculosis. Tuberculosis, rarely you will find hypopyon. The only condition, or the most likely explanation, is by the use of rifabutin. If you find a patient with hypopyon, don't think on tuberculosis as a first option, and think on especially HLA-B27 uveitis. So the answer for these patients, or for this question, is that it is most likely a medication of the rifabutin. Now we will mention a few words about the testing for tuberculosis. All of you know the most famous skin test, which is the intradermal skin test, Tuberculin Skin Test, also known as the purified protein derivative, or the MANTO test. And this test based on the delayed hypersensitivity reaction created in the body against the Mycobacterium bacilli antigens, and it will provide information about previous exposure, but will not give information about whether the disease is active or not. So if most of us, we will be positive for this test, so we are named as latent TB because of the previous exposure either to the tubercle bacilli itself, or even atypical mycobacterial bacilli also will give positivity to this test. So that the interpretation of this test should be guarded in view of the BCG vaccination. The size is more, the size of the induration is more important than the redness. It is said that if it is more than 5 millimeter induration, will be significant and considered positive in HIV patients, and those who are in close contact with tubercular TB patients. And this will be strongly suggested for chest X-ray to exclude all tuberculosis. Now, if it is more than 10 millimeter in duration in a diabetic patient or patient with immunosuppression or renal failure, this is very significant, especially in endemic countries. And if it is more than 15 millimeters, this is strongly positive even if the patient is receiving BCG vaccine. This should be considered seriously, and further multimodal imaging should be done for the patient to confirm whether he has all TB or not. The other famous or the recently invented one is the IGRA test, which is the interferon gamma release assay. There are two tests, the TB spot gold and the TB spot. Okay, the TB gold measures the quantity of the gamma interferon released, and the TB spots measures the gamma interferon producing cells. Now, this test is important and is recommended by the WHO because of it is preferred because of its higher specificity, as these antigens are absent in the BCG vaccine. This antigen, that is the EST6, and these antigens, this is sensitive. Again, the IGRA test detect these antigens, and these antigens don't cross-match with the BCG. That's to say, if the patient has received the BCG vaccine, this doesn't mean that he will have positive IGRA test. So it is more specific and is preferred. However, this test in endemic setting, the sensitivity will drop down, and also it will not be able to differentiate between latent and active tuberculosis. The recommendation by the WHO is the combining of the both, the TB, the TST test, that's the Tuberculin Skin Test, and the IGRA test is more effective than using either test alone. So this is the two types of the IGRA tests. Now we will revise together some of the immunological tests that we have to do in a presumed ocular tuberculosis, namely the IGRA test, that's interferon gamma release assay, and the Tuberculin Skin Test. The IGRA test, also known as the quantiferon TB gold test, which has a high specificity and high sensitivity, reaching up to 90% for both of them, means that it is supportive for the diagnosis if it is positive. However, if it is negative, this does not rule out tuberculosis. However, Tuberculin Skin Test has lesser extent sensitivity and too much low specificity, and the reason that it is confounded by the BCG. You know that when a person receives BCG vaccination, so the tuberculin test becomes not that much reliable unless very strongly positive, more than 15 millimeter of in duration. Another thing, that the tuberculin test is cheaper, but you need more than 2 visits to see the result, because the result will appear between 48 to 72 hours, unlike the quantiferon test. So the general recommendation from the cost consensus that we have to support our clinical finding by this immunological tests. However, IGRA is preferred over the tuberculin test, and the reason for that is because of the BCG vaccination. And as I said, that active or positive test will support your diagnosis. However, negative test does not rule out the diagnosis. So we will have different lines or layers of assessment of the case based on the clinical presentation. As I said, there are some phenotypic presentation of the presumed ocular tuberculosis which are strongly suggestive of tuberculosis, like the serpiginous-like choroiditis, vasculitis, tuberculoma, or granuloma. If you find these pictures, this is highly suggestive, but you have to support this by some investigation using the multimodal imaging, starting with the fundus autofluorescence. It has specific features, and OCT, fluorescein angiography, ICGA, and OCTA. All of these have specific peculiar finding that gives clue to the underlying etiology and point to the evidence of tuberculosis. Then we support with this with the immunological test, as we said earlier, and then we have to do chest X-ray or CT scan. CT scan is preferred over the chest X-ray as advised by the consensus. And after this, if you have any strong evidence supporting the clinical finding, you can go one step further and exclude mimickers for these presentations, like syphilis, sarcoidosis, and Behçet disease, by doing some investigation to exclude these mimickers. And then if you have the facility to do the PCR or the gen expert from the aqueous fluid, this also will be very strong basis for the diagnosis, because we are planning now, if all this we pass all these steps, we will go to the final steps, which is the trial of anti-tubercular treatment. Now, based on this finding, if you start the anti-tubercular treatment, the patient will have a response, and accordingly you have successfully managed the case. So this is very important. Based on the advice from the consensus, you either have a definite diagnosis of TB, and this is very difficult. When we say definite diagnosis, if you have isolated the acid-fast bacilli from the aqueous or ocular fluids, and you have a positive culture confirmed by the PCR, and based on the clinical compatible with the clinical features, this is called definitive diagnosis. As we said before, because of the ocular tuberculosis is paucibacillary, the isolation of the acid-fast bacilli from the aqueous fluids is very difficult, so this possibility is very low. However, if you have a probable diagnosis, means that you have a clinical picture consistent with tuberculous uveitis with positive immunological testing, and we have excluded the mimickers, but you have no strong isolation, or there is no isolation of the organism from the aqueous fluids, and the patient shows a positive response to anti-tubercular treatment. So you have a clinical features supported by serology, and you exclude the criteria, even if the chest X-ray here is not showing any finding, but on applying the anti-tubercular treatments, you have a positive response. So this is called probable diagnosis. Now, for a possible diagnosis, you have a clinical feature consistent with tuberculosis with an endemic area. For example, you are in an endemic area, and after exclusion of other causes or mimickers, but you have no strong immunological tests, or you have only one immunological test. So this is called possible diagnosis. As we said, we have to run through all these steps to reach to the final diagnosis, because the exact diagnosis of ocular tuberculosis is not easy, and it is very difficult. Now, as far as the treatment strategy, we will speak generally general guidelines. We have different regimes, but this is the standard regime using the first-line drugs, which is named as HRZE regime. H stands for isoniazid hydrazide. This is a WHO terminology. So it is made up of four drugs used intensively for 2 months, followed by another 4 to 7 months using the isoniazid and rifampicin. It is named as like this 2HRZE 4HR. It means that 2 months the 4 drugs, and then another 4 months the other drugs. The reason why the duration is not fixed and can reach it up to 9 to 12 months after surgery, because as we said before, that ocular tuberculosis is extrapulmonary tuberculosis, and the treatment is not standardized as in pulmonary tuberculosis. The treatment here is based on the presentation, the phenotypic presentation, and the high probability of being tuberculosis, but there is no definite laboratory isolation of the organism from the aqueous fluid or from the vitreous, so that it is a presumed ocular tuberculosis. That's why the continuation or discontinuation of the treatment is based on the response to the treatment medications, and that's why it can reach up to 12 months. The duration for extrapulmonary tuberculosis treatment is more than the pulmonary tuberculosis itself. Now, other drugs that you can use it along, like the steroids, and it should be used after the initiation of the treatment, at least by a few weeks after starting the treatments, to minimize the immunological damage that happens inside the eye. Other drugs like anti-VEGF for the treatment of persistent macular edema and also new vascularizations. You can do laser photocoagulation, surgical intervention in the form of parsiplana vitrectomy and scleral buckling, and so on. But the mainstay of the treatment, that this is the first line defense or the first line treatment regime using this for medication. This is for people who have mycobacterium that's sensitive to these drugs, because later we will discuss about the emerging resistance to anti-tubercular drugs. So this line will not be suitable for them, and we have to shift to the second line. Okay. Another point that you will find in the box when you read RIB regime or HRZ, both are the same. H stands for isoniazid, and here it is they use the mnemonics RIB, rifampicin, I for isoniazid, but both of them are representing the same first line anti-tubercular treatments. Now, this is the drugs, as I said. The important point that I want to emphasize here that we discussed before about the ethambutol and its risk for being associated with toxic optic neuropathy, especially if used for doses, high doses, more than 15 to 20 milligram per kg per day. So for longer duration, as I said, that treatment can continue for 12 months and sometimes even more than 12 months in some cases. So keep in your eyes watching the possible complication of the ethambutol. And you will discover later that due to the newly emerging drugs, there is no more ethambutol toxicity because they're using another generation of drugs with another complication that we'll discuss about it later on. So remember that ethambutol, one of the causes of toxic optic neuropathy, that itself might precipitate the deterioration of the visual function of the patient. Now, another point that I want you to keep it in your mind, that there is an immune-related response that's initially, once you start anti-tubercular treatment, you will notice worsening of the patient's inflammations and the situation, and this immune response is related to the mycobacterium antigen becomes more exposed, so that this is known as Herxheimer-like reaction or immune-related uveitis, like the same one when we spoken about the management of cytomegalovirus or herpes virus uveitis in a patient with HIV. After starting the treatment and improvement of the immunity of the patients due to the heart treatment, so that the notes worsening of the inflammation inside the eye, this is called immune-related uveitis. Now, my advice for this, or what's the solution, that you have to increase the dose of steroids. Don't to stop the anti-tubercular treatments and continue your medication. This is the point. This is the trick. So if someone asks you, once you start anti-tubercular treatment and you have no solid background regarding the exact etiology of the disease, and you notice worsening of the uveitis or uveitis of the patients, what you'll do, tell him that I have to exclude the immune-related reaction due to the use of anti-tubercular drugs, and after that you will decide whether to continue or discontinue the medications. As I said, that a latent tuberculosis, in which you find a patient with positive immunological testing, but he has no any clinical pulmonary tuberculosis. And the WHO recommend to treat even these patients, even just you find patient with granulomatous uveitis with highly suggestive of tuberculosis, but you have no strong evidence based on the radiology or the lung manifestations. You just only have the serological tests. You need also to treat them, especially if they have special phenotypic presentations like the serpiginous choroiditis or the presence of vasculitis, also the presence of tuberculoma. All these are a strong indicator for the use of anti-tubercular drugs. Moreover, the WHO recommend that even if you are planning to use immunosuppression for your patient for whatever reason, or the use of biological treatment, before the use of immunosuppression or any biological treatment or any steroid-sparing drugs like methotrexate, azathioprine, you have to have a screening for your patient for tuberculosis. And if you find him serologically positive for TB, you have to give him anti-tubercular drugs. Now, the regimes are different. For example, for a preventive treatment, as I said, for patients with immunosuppression, you are willing to do immunosuppressions. This is different regimes, like this one, 3HP regime, which stands for 3 months of isoniazid with rifampicin, or 1HP regime, which is just only the isoniazid and rifampicin daily for 1 month, or the 4R, which is rifampicin, use it for 4 months. This is for prevention. So you'll find that there is different regimes based on the situation, ranging from latent TB to a prevention to an subclinical infection to an active pulmonary tuberculosis and so on. And it is highly recommended that before you use any immunological treatment for whatever reason, you have to do screening for tuberculosis. This is mandatory. Now there is one important study or consensus you need to know about it. That's the collaborative ocular tuberculosis study, known as COTS consensus, which organize the behavior of the doctors towards the ocular tuberculosis, how to manage the cases briefly. So this consensus, you should know about it because you will be asked about it. They say that in the presence of anterior uveitis, tubercular anterior uveitis only, you need in all the situation, before you start anti-tubercular treatment, there should be a strong radiological evidence of exposure to tuberculosis in the form of cavitations or calcification in the apex of the lung, or by the CT scan. You have to have radiological support along with the two immunological tests, that's the purified protein derivatives, that's the tuberculin test or the IGRA test. In the presence of these criteria, this strongly suggests the use of anti-tubercular drugs. However, the regime also forgive for only one immunological test positive and the other is negative, but it is mandatory to have a positive radiology test. The only exception that if you are in endemic area, this is maybe an excuse, but they strongly recommend that in the presence of positive radiology test, along with one or two immunological tests, you have to use anti-tubercular treatment. Otherwise, if you are in non-endemic area and you have one test is negative, there is no indication to use anti-tubercular treatment. And this is the risk because of the risk of toxicity from the use of these drugs. Now, for intermediate uveitis, the same. It is must and mandatory to have a radiological evidence of tuberculosis along with the two immunological tests are positive. This is strongly recommended for the use of anti-tubercular treatment. Also, they forgive for only one immunological test is positive in a non-endemic area. This is not allowed to do anti-tubercular treatment. However, if you are in an endemic area with only one immunological test, you should use anti-tubercular treatment. Now, the regulation is more forgiving for posterior uveitis. Now, posterior uveitis, they classify the management based on the phenotypic presentation. Some phenotypic presentation of tuberculosis are strongly suggestive of tuberculosis, like serpiginous-like choroiditis and the presence of choroidal tuberculoma. Both of these two are very strong phenotypic presentation that mandate the use of anti-tubercular treatment even in the presence of only one immunological test or in the absence of radiological evidence of tuberculosis. Based on these findings, you can use the anti-tubercular treatment. As you can see, even if there is only one test is positive, in the absence of radiological evidence, you can use the anti-tubercular treatment. However, if the patient presents with multifocal choroiditis or recurrent choroiditis, along with other anterior segment involvement, they restrict the use of anti-tubercular drugs unless in the presence of radiological evidence or in very special situation in endemic areas, along with the two immunological evidence. Along with the radiological evidence, you can use anti-tubercular treatment. So the strong suggestion or the strong phenotypic presentation that mandate the use of anti-tubercular drugs is serpiginous-like choroiditis and choroidal tuberculoma. Keep it in your mind. If anybody asks you, if you find a patient with serpiginous choroiditis, do you wait for the X-ray evidence for all tuberculosis? The answer would be no. Just one immunological test is enough to start anti-tubercular treatment because this phenotype is very peculiar to tuberculosis. However, if you find multifocal choroiditis or other evidence of posterior segment without these two immunological tests, here the decision will be based on the endemicity, whether the patient in endemic area or not, and whether there is any other associated finding. All of this will favor the use of anti-tubercular drugs. This is the second line. Now, the second line meant for whenever there is drug resistance, the principle of drug resistance, like MDR or XDR. These are different types of drug resistance defined by the WHO, so that instead of the first line, they use the second line. You need not to memorize all of them. Just keep in mind that fluoroquinolones like moxifloxacin and levofloxacin can be used for tuberculosis, and MDR stands for multidrug resistance. for isoniazid and rifampicin, and also the XDR stands for this is the XDR stands for resistance to bedaquiline and linezolide. I will explain it later on. So there are different types of drug resistance has been defined by the WHO. Now, the recent and the more novel drugs that's used for anti-tubercular treatment, you should just have an idea about them because they are important, especially for in extrapulmonary tuberculosis and also in special categories like in children. For example, this one, dilamanide, is used mainly in children, and there is special protocols for drug resistance because now the emergence of drug resistance to tuberculosis is very prevalent. So the classical first line treatment is no more effective. So the doctors are shifting or there is a paradigm shift towards the novel drugs, especially the bedaquiline and britomanide and linezolide. Now, this linezolide is off-label, is not FDA approved, but it is extensively used, especially in special regimes known as the PPAL regime, which is one of the strong regimes for tuberculosis-resistant strains, and it is similar to the ethambutol. It is associated with toxicity to the optic nerve. So that's why nowadays there is a shift of the emergence of this anti-tubercular drugs regime or drug resistant regimes has shifted the neuroophthalmic toxicity beyond the ethambutol, but now becomes toward linezolide associated with mitochondrial optic neuropathy. It has the similar presentation as optic as ethambutol in the form of affection of the temporal side of the retinal nerve fiber layers, and the changes that happens in the visual field in the form of central scotoma and centrocecal scotoma. So for you as a postgraduate, remember this drug because this is similar to the ethambutol toxicity, and this might be asked by any of the doctors about what you know about the novel or the recent drugs used in tubercular treatment. Now we will briefly shift the discussion to an important silent threat of vision accompanying the therapy for tuberculosis, which is the ethambutol optic neuropathy. And definitely, if you face a case of tuberculous uveitis, the examiner will ask you about this complication of the medication for tuberculosis. So for you as a postgraduate, you should know a few words about this topic. Starting with the definition of ethambutol optic neuropathy, defined as toxic optic neuropathy that's caused by ethambutol therapy. Usually, when you continue the medication more than 6 months, it carries high risk. However, it has been reported even after the initiation of 2 months. But there are certain risk factors. They increase the incidence of this complication. One of them, when the patient receives a daily dose more than 15 milligram per kg per day. Usually the dose between 10 to 15 milligram. However, if he received this one for longer duration, more than 6 months, this carries high risk, especially if it is there is comorbidity with diabetes or renal impairment. The incidence will be more, and the more the age of the patient, the more the risk of this complication. The underlying pathogenesis, because the mechanism of action of ethambutol, it works on the mitochondrial metabolism. The oxidative phosphorylation of the mitochondria will be interrupted because of the chelation of the copper and zinc. This happens inside the Mycobacterium bacilli, but this also will affect the host cells itself. That's why the papulomacular bundle are the most vulnerable for these complications and lead to ganglion cell loss. The cells, initially there will be interruption of the exoplasmic transport, and then at the end there will be damage to the ganglion cells and lead to temporal atrophy of the optic disc. So this is the basic mechanism or the underlying mechanism due to mitochondrial dysfunction or interruption of the oxidative phosphorylation that happens in the mitochondria. And this is similar to other toxic optic neuropathies, like what happens in nutritional deficiencies or in methanol toxicity, or even with isoniazid. All they are related to the mitochondrial dysfunction. The special thing that the papulomacular bundle are the first structures to be damaged, because the papulomacular bundles, they have long course within the retina and they are unmyelinated, so they are very prone to this toxic effect. Unlike when we spoken in glaucoma, that the papillomacular bundle are the last to be affected in glaucoma. That's why keep this in your mind to understand the visual field changes and the OCT changes that we will speak about it later. As I said, it is usually bilateral, start as asymmetrical, then becomes symmetrical. Patient will complain of this metamorphopsia. Visual field, you will see central or centrocecal scotoma with reduced contrast sensitivity, and usually the visual acuity is good initially and later on will be affected. Now, for early detection, we have to do our best for early detection of this problem, because if you detect it early, this is reversible and you can stop the drug and arrest or revert the changes that happens in the macula or in the optic nerve. However, if you delay the stopping of the drugs, the changes will be permanent and the patient will have bilateral optic atrophy. Now, the changes will range from changes on the symptoms of the patients. You'll find color vision changes. The patient will have dyschromatopsia, and also the contrast sensitivity of the patient will be reduced. As a functional changes, the visual field also will be, you'll find central scotoma and centrocecal scotoma, and also the early signs is the changes in the VEB. You will find delay in the P wave, in the latency, as well as in the amplitude. As far as the structural changes that's seen by OCT, there will be two changes at the level of the ganglion cell inner plexiform layer complex and at the layer at the level of the retinal nerve fiber layer. Both of them, they will show thinning of the this area, and these are one of the early signs. However, the changes in the ganglion cell complex precedes the changes in the retinal nerve fiber layer. So if you have VEB, this is the best one for early detection. But if you don't have the VEB, you can rely on the structural OCT and concentrate on the ganglion cell complex. If you notice any thinning, this will be there will be a problem. Now, how you recognize the thinning? Because before the initiation of anti-tubercular treatment, you should have a baseline assessment of your patient as far as the visual acuity, the color vision, the contrast sensitivity, the visual field, and the OCT. This is the minimum requirement before you start your anti-tubercular treatments. And if you discovered monthly any deviation of the patient's parameters from the normal or the baseline reading that you have taken before the initiation of treatment, this will point to or give a clue for the toxicity with ethambutol. As I said, keep in your mind that changes in the ganglion cell complex will precede the changes in the retinal nerve fiber layer. This is very initial changes. As I said, it starts in the temporal area and then will proceed in a clock hour appearance. I think this is another picture for the fundus patient with temporal pallor. This is a patient with temporal pallor, and this is patient with advanced stage. This is advanced stage. That's affection of the ganglion cell complex. You can see all the area are red, so he has very thin area in the macular area, and this is because of the toxicity with ethambutol. Now, to understand the changes that happens in the retinal nerve fiber layer, this is the Tisnet graph. As you know, this is the Tisnet graph. This is the normal distribution of the thickness of the retinal nerve fibers based on the Isnet rule. Isnet rule says that the inferior part is more thick. This is the double hump. The inferior part of the optic nerve or the retinal nerve fibers layer is thicker than the superior part, and then the nasal, followed by the nasal part, and the last one is the temporal part. This is the normal distribution of the double hump appearance or the Tisnet graph that's seen in a normal people. Now, what happens in early stages? In early stages of the toxicity, the first thing that changes, as I said, in the maculopapular bundle. So you will find small drift of the patient's data towards in the temporal area. So you can see here the temporal area, there is mild deviations of the thickness of the retinal nerve fiber layer. Then it will proceed to involve even the temporal and the nasal area. This is moderate affection. And in advanced stages, you will find generalized or global reduction of the thickness of the retinal nerve fibers involving the all parts. You can see the all clock hours area of 3.5 millimeter around the optic disc will be very thin. So this will be advanced stage. So based on your understanding of this Tisnet graph, you can assess your patient and see if there is any evidence for toxicity. Now, similarly, this is the changes that happens in the visual field. The patient will start with central scotoma, centrocecal scotoma, and then will progress to generalized constriction. And at the end, there will be generalized constriction of the visual field, as you can see here in this patients. And finally, this is summary for what we have mentioned. Keep in your mind the earliest changes will be visible and early can be detected by the VEB, and you find latency in the P100 wave, also the amplitude. And then after that, the changes will happen in the OCT in the ganglion cell complex, followed by the retinal nerve fiber layer. And the last thing to be seen is the visual field. So visual field assessment is late sign. You should not wait till the changes happens in the visual field. You should detect your patient as early as possible. Now, one of the important dilemma that might lead the doctor to mislead in the diagnosis, that how you differentiate between optic neuropathy due to tuberculosis itself, due to the natural progression of the disease itself, and from ethambutol toxicity, because the distinction between these two is very important. Why? Because if you by mistake you diagnose the case as ethambutol toxicity and you stop the ethambutol prematurely, this can lead to the emergence of drug resistance, and the patient will not respond anymore to your medications. And if by mistake you diagnose the case as optic neuropathy due to tuberculosis and you continue the medication, in a case of ethambutol toxicity, you will end up by bilateral optic atrophy. So the distinction is very important. There are certain red flags for suggesting toxicity. First of all, toxicity, you will find bilateral changes in the patient's symptoms, as well as in the documented visual field changes and OCT changes. You will find bilateral changes, and also at the same time you will find improvement in the systemic symptoms of the patients. However, in the presence of progression of the tuberculosis itself, and the patient develops optic neuropathy due to tuberculosis itself, first of all, the pain and headache, this is known as meningism. The patient will have tuberculous meningitis due to CNS involvement, and he will have pain, multiple cranial nerve pulses. The visual field will be consistent with the area of affection of the chiasma or the optic tract, so there will be no classical centrocecal scotoma as you see here. And the definitive changes you will be seen in the MRI, and you find the enhancement of the optic nerve and the changes that's seen due to tuberculous optic neuropathy. So this is very important to keep it in your mind. But however, in clinical it is sometimes difficult to differentiate, especially if the patient already progressed to tuberculous meningitis, for example, and he is already have ethambutol toxicity. So in this situation, the distinction between both of them will be very difficult. However, as I said before, that although the incidence of ethambutol toxicity is low, is not that much high. However, it is the classic example of optic neuropathy and remains the prototype for different anti-tubercular drug toxicity, because the emergence of the new multi-drug resistance and the different protocols for the anti-tubercular treatment, namely the linezolid drugs, which also one of the drugs that's responsible for the mitochondrial optic neuropathy associated with this treatment. As we explained before, that ethambutol responsible for one of these mitochondrial optic neuropathy, and now the second one is linezolid. And so in the areas where they don't use ethambutol and use these medications, you will should keep your eyes watching the changes that happens in the optic nerve, because even this drug can cause optic neuropathy. However, this doesn't mean that the incidence of ethambutol toxicity is eliminated, because still in plenty of endemic areas in the world, they're still using ethambutol as one of the main first line drugs in the treatment protocols. So still there are cases of ethambutol toxicity. Now, the management is simple as that once you confirm that there is ethambutol toxicity, immediately you have to document this by the OCT and the different investigation that we have mentioned before, and then you have to discuss with your team, and especially those people who are dealing with the case if he has pulmonary tuberculosis, before stopping the drug. You should not stop the drug by yourself. You should discuss with your team and then decide to stop ethambutol and use any alternative medications for continuing the treatment. As I said, the early detection is very important because the changes are initially reversible. However, if you lately diagnose the case, the changes will be irreversible. And your weapons, as I said, that you have to follow the patient serially by OCT, compare it with the baseline reading. You follow your patient with VEB, you follow the ganglion cell complex, and so on. Keep it in your mind that if you are waiting to diagnose ethambutol optic neuropathy by waiting the signs and symptoms from the patient, you will be very late. You should depend on objective means to determine ethambutol toxicity and not subjective means. Now, as far as the prognosis and the visual outcomes and the future prospect, now the good thing that we could achieve a 70 to 80% success rate of that case is picked early and treated early, and any delay in the treatment of this patient, especially if more than 3 months, will carry a bad prognostic signs. Other bad prognostic signs is the presence of macular edema or optic neuropathies or optic nerve involvement, or if the patient develops resistance, multidrug resistance, or XDR resistance, as we explained before, to the anti-tubercular treatment, and also the presence of new vascularization with severe ischemia or retinal detachment. All these are bad prognostic signs. So we can achieve up to 70 to 80% success rate, and recurrence can appear in 10 to 20% of the patients after the initiation of anti-tubercular treatment, and prematurely we stop the treatment, for example, after 6 months or 8 months. So the recurrence is suggestive of inadequate treatment. Now, the future prospect, as recommended by the WHO, as we said before, that the use of a gene expert is very important and very useful, especially in pulmonary tuberculosis. However, it is now tried on ocular tissues to be tested whether it is effective also and of value in early detecting tuberculosis of ocular involvement. As a final message, multimodal imaging, including the fluorescein angiography, fundus autofluorescence, and ICG and OCT, structural OCT and OCTA, all supported by laboratory and serology investigation, or are needed for definitive diagnosis. And recently, the introduction of the artificial intelligence for the pattern detection of cases for presumed ocular tuberculosis also has broadened the spectrum for early detection of this serious problem. Now we nearly reached to the end of this session of this master class. And before I leave my position, just I would like to remind you that the early diagnosis and the prompt anti-tubercular treatment is the cornerstone for preserving not only the vision of the patient, but also the quality of life of the patient. So never underestimate tuberculosis as a cause of uveitis, particularly in endemic regions. And when you have a patient with atypical recurrent inflammatory disease, keep it in your mind, because early diagnosis and timely anti-tubercular treatment is the, as I said, not only the saving for his vision, but also improve the quality of life of this patient. Now, this is the important references that I utilize to provide this lecture. And the next session will be regarding syphilitic uveitis. We move from one big masquerade of ocular inflammation to another mimicker of ocular inflammations, which is the syphilitic uveitis, where also the diagnostic challenges and the dilemma becomes equally fascinating and clinically challenging as well. So I thank you very much for your attention and your dedication for learning, and your commitment for learning in this lecture. And I hope I meet you in the next session in syphilitic uveitis. Thank you very much.